Hello, my name is Renee Bullock-Palmer. I'm a board-certified cardiologist at the Boer Heart and Lung Hospital Center. I also serve as a course director and faculty for CVI's annual meeting in the female patient, imaging in the female patient program that's held in the fall each year. And I'm also a course director and serve as faculty for CVI's annual updates in echocardiography. Welcome to CVI Heartbites. So CVI Heartbites is a free, non-accredited educational program produced by Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses on cardiovascular disease in the age of COVID-19, best practices in the Nuclear Cardiology Lab during the COVID-19 pandemic. Please note that this presentation was recorded on April 29, 2020, and the information was up to date as of that time. At the end of my presentation, you will see some additional resources and have the opportunity to contact me with any questions that you may have. So as mentioned today, I'll be speaking on the best practices in the Nuclear Cardiology Lab during the COVID-19 pandemic, and I have no disclosures. So as some of you may know, the COVID-19 virus is, the disease is an infectious disease caused by a new virus, and the disease predominantly causes respiratory illnesses similar to the flu, with symptoms such as cough, fever, and in severe cases, difficulty breathing. As the disease situation has evolved with the pandemic, we're even learning about other manifestations of this disease, where it may manifest with cardiovascular symptoms and complaints, such as even chest pains, and in some rare cases may present even similar to a stroke. So you can protect yourself by hand washing frequently, avoiding touching your face, wearing a mask in public places, and avoiding close contact of up to 3 feet to 6 feet from people who are not feeling well. There is currently no vaccine at this time to prevent this coronavirus 2019 COVID-19 virus. And the virus is thought to spread mainly from person-to-person contact between people who are in close contact with each other within about 16 feet. It's also thought to be transmitted by airborne methods, and also through respiratory droplets produced when an infected person coughs, sneezes, or talks. There's also the asymptomatic spread that is possible as this virus is airborne. So as of April 9th, 2020, we had over 500,000 confirmed cases and close to 20,000 deaths. But as of today's date, April 29th, 2020, unfortunately, this disease continued to spread, and we at this time have over 1 million confirmed cases in the United States and over 60,000 deaths. The disease has spread predominantly in the coastal regions, but as is being shown increasingly, the spread also has involved some Midwestern, some Mideastern states. So as I mentioned, there's no vaccine or any effective treatment at this time, and of course this may evolve as time progresses and more studies have been shown to show effective treatments. So for today's topic, I'm going to delve directly into a recent publication that was in the Journal of Nuclear Cardiology that was chaired by Dr. Scally, that looked at the guidance and best practices for nuclear cardiology labs during the coronavirus pandemic. And this is an information statement that was released jointly by the American Society of Nuclear Cardiology and the Society of Nuclear Medicine and Molecular Imaging. So there are 3 key points to remember. That during this pandemic, it's very important to postpone all non-urgent studies, and also to perform at this time only urgent studies that are likely to change a patient's management and outcomes in the near term in your outpatients, and to expedite discharge for inpatients and emergency room patients. It is very important to screen appropriately before the patient arrives to the hospital and at the time of their arrival to the lab. Now, this is a patient's journey through the nuclear lab. So of course, that journey begins from the moment the test is ordered in the outpatient clinic or the inpatient service before the arrival of the patient. There are certain instructions that the patient has to be aware of before their arrival. And of course, at the time of the arrival of the patient, there's an intake that the technician and the nursing staff may screen the patients. And also at the time of the resting study, there's a radiotracer injection and image acquisition, followed by the stress testing, and ultimately leads to the interpretation and reporting of this study. Now, there are some important things to remember before the arrival of the patient, especially during this pandemic. The nuclear cardiology study should only be performed if it is expected to provide clinical benefit. And as I had mentioned, the test should be postponed until a later date if this test is not deemed to be urgent. Now, most elective studies can be postponed at a later time, and any elected patient recently exposed to someone with the coronavirus or has symptoms of the virus should be canceled or rescheduled as soon as it is safely possible. Now, all patients should be scheduled for nuclear testing. They should be screened for infection according to the local protocols and methods for quarantine in your institution and in your state. Very important that patients are kept at a far enough distance from each other of at least 6 feet, sometimes in a separate room if possible, to use one particular machine for certain patients, as particularly if there's a suspected COVID case, you'd like to ensure that that machine is specific for that patient and is deep cleaned before any other patients may use that machine, and particularly for these cases that are suspected or confirmed. Now, at the time of the arrival of the patient to the lab, the front desk receptionist, it's very important that the nursing staff and or the technology staff is there to screen the patients and any accompanying persons, and that the accompanying persons for these patients should be minimized as much as is safely possible. The patients and staff should wear masks at all times while they're in the nuclear lab, and there should be a separation, as I mentioned, and social distancing of the staff, patients, and the accompanying person. Meticulous hygiene with deep cleaning of the waiting area, as well as the stress test room, imaging room, and recovery rooms and restrooms, as well as the radiopharmacy rooms, is very important at the end of the day and also in between patients if there's a suspected case. Now, there are certain questions that should be answered by the patient prior to their arrival, preferably, and also at the time of arrival for screening. And some of these questions includes the presence of a fever, the presence of a cough, the presence of difficulty breathing, if there's any unusual fatigue, if there are any muscle aches or joint aches, if there's any intestinal complaints such as diarrhea or nausea, if there's a loss of smell, a loss of taste, and also if there have been an exposure to any persons with the virus in the last 2 weeks. Also, it's very important to ask if they have been exposed to any person who may be at high risk for getting the virus in the last 2 weeks as well. And also a question about his history of travel to any place where there may be a high incidence of this disease. So proper screening begins before their arrival at pre-appointment, at the point of entry to the institution, and at the front desk. It's very important that the technologist is also involved in this process, as they will work with the physicians to reduce any non-urgent testing. It's very important for the technicians and nursing staff as well to limit their time with patients as much as is safely possible and as much as is practical. Explaining the exams takes a lot of time, and there are some institutions that may even have this explanation occur by telemedicine the day before the study to minimize exposure to the patients. It's very important that the technologists work as a team and limit their staff exposure, and there should be judicious use of PPE, personal protective equipment, such as masks, gowns, and gloves. Distancing the staff members is also important, and changing physical workspaces to accommodate this increased distancing of the staff. Now, during the stress test, it's very important that you consider verbal consent if this is possible within your institution instead of written, as this will allow you to get the consent even by telehealth if this is possible and if it is supported in your institution. Now, what has been noted is that with exercise, with exhalation of air, there can be aerosolization of this virus, and therefore it's recommended that exercise stress testing should be avoided as much as possible, and preferentially using vasodilatory stress testing should be considered to minimize exposure to the virus for patients, especially who may have asymptomatic spread. Also important to shorten the test to reduce exposure time, so you may opt for a more shorter stress protocol. And blood pressure monitoring with automatic equipment is also helpful, which allows for distancing from the patient during the test. As I had mentioned, preferably using a rapid acquisition protocol, and also using vasodilatory stress tests instead of exercise stress testing. Now, the image protocol selection is important. Now, you may prefer, it might be wise to select the protocol with the shortest duration of scan time and exposure to the staff, and you may consider using a standard dose imaging with rapid imaging protocol, particularly if you have the ability to do iterative reconstruction with wide beam reconstruction to allow for that. You may also want to consider stress first imaging, and therefore limit the use of even resting imaging if the stress test perfusion is completely normal. And you may also consider single day imaging protocols, particularly if your patients are morbidly obese and present for a 2-day protocol. It would be ideal to do the stress test first on the first day and minimize the need for a rest study if the stress study is normal on the first day. Considering attenuation correction imaging is also vital, as if you have the stress test done initially and your attenuation correction completely looks normal, then that resting study may be avoided. Cardiac PET imaging is also valuable and may be preferred if you have the cardiac PET available at your institution, as this allows for rapid throughput and minimizes the time spent by the patient in the lab. Now, with regards to image interpretation and reporting, what's very important here is in the era of social distancing to avoid multiple physicians and trainees in the same room as much as possible. And you may even be able to review these studies remotely through teleconferencing and screen sharing for image interpretation. And of course, make sure that these systems are HIPAA compliant if you're sharing the screen with the rest of the trainees or physicians in the institution. If you do have a hybrid camera with a SPECT CT system, it's very important that CT images that are acquired for attenuation correction are reviewed in the context of possible COVID-19 pulmonary findings. And ideally, these images should be reviewed expeditiously before the patient is discharged to home, as early CT findings in COVID-19 can include bilateral and peripheral ground glass formation and consolidation with opacities within the lung. So be careful to review the CT images for these findings and consult with any infectious disease experts if there is a suspicion for this finding of COVID-19 on the CT study. Also, avoid in-person image review with referring services and use remote reviewing when possible. That's HIPAA compliant with the screen sharing to review any particular studies with a referring physician. Also, telephone discussions may also be useful in that regard as well. So the key steps to minimizing this exposure in the lab includes 4 main steps. 1, as I mentioned, before the arrival of the patient, screening the patients by phone, triaging the patient's risk for COVID-19, and postponing any non-urgent studies. And then the second phase is at the arrival of the patient in the lab, making sure that the patients and staff are fully masked throughout the entire stay in the lab, and that the healthcare professionals have adequate use of personal protective equipment, PPE, and that the patients are screened at that time of their arrival by history again, and also with a temperature check at the time of their arrival. Very important to separate the patients at least 6 feet between each other and minimize attendance within the room. Again, it's important that the test that the patient presents for, that the appropriate use criteria is reviewed to ensure that the indication for the study is appropriate. Now, during the test, minimizing contact for written consent might be considered, and to use verbal consent if possible, preferentially using a rapid protocol for imaging, and preferentially using vasodilator stress testing rather than exercise stress testing when possible, and also to ensure that the rooms are deep cleaned and the equipment is deep cleaned in between cases, and also at the end of the day, particularly in between cases for patients who are suspected or confirmed to have COVID-19. Now, after the test, avoiding sharing computers and sanitizing keyboards between physicians. Use of telehealth is also very vital in this regard, as you can also review the studies remotely with your trainees and other physicians, and also using telehealth when possible to discuss results between teams, cardiovascular care teams. And also ensure that if you do have a hybrid SPECT or PET CT system, that the CT findings of the study are reviewed expeditiously right after the scan ideally, and acted upon if there are any suspicious findings for COVID-19. Now, what we are finding interestingly as we're going through this pandemic is that many hospitals nationwide have noted that there have been a significant decrease in the amount of ST elevation MIs presenting to the institution. And in this recent publication by Jack in 2020 had shown that there's been at least a 38% reduction in the STEMI presentations nationally at many hospitals. So the big question is that where are all these patients? Are they staying home, being fearful of going to the hospital for care? Or are they dying of heart disease at home? Or also, are they dying from the COVID-19? Because as you may know, these patients with heart disease are at increased risk for increased mortality with COVID-19. So with this absence of patients, the question that we all have to ask within the cardiovascular community is that after this pandemic is finished, or towards the end of this pandemic, particularly when social distancing restrictions are lifted, are we going to see a surge of cardiac patients presenting to our institutions for cardiac evaluation and cardiovascular care? And in so thinking, how do we prepare our nuclear labs for this surge in patients? It is foreseeable that we may have to add additional testing slots for increased diagnostic testing as we prepare for this surge of cardiac patients. And we may also need to still use rapid testing protocols so that we can increase the throughput of our labs to ensure that we're doing as many patient studies as possible to satisfy the demand. And also, we may have to also, again, do stress first protocols that might be useful so that we can increase throughput of our lab. And finally, to ensure that the patients are being appropriately referred to for testing and that the indication for the test is appropriate. That is most important, as you would not wish to have a test done for an inappropriate indication. So there are additional resources that are available online, and I have left this here for your review. And there's also a webinar that will be conducted by the American Society of Nuclear Cardiologists that will be focused tomorrow night, April 30th, on preparing our nuclear labs for the post-COVID-19 world. And I am thankful for this opportunity to present this evening. And if you have any questions for me, please email the CVI Executive Director, Mr. Mark Hartnett. That's on the screen as is shown. And please feel free to share this link with anyone who might be interested in this information. And let us know if there are any other topics of interest that you may like to have us discuss in this very important platform. Thank you for watching this CVI Heart segment. And for more information and for other CVI Heartbites segments, as well as any other CVI educational programs, please visit us at cviphiladelphia.org and follow us on Twitter at CVI_Philly, PHILA, #CVI Heartbites. Thank you. Good night.